Hello everyone, I'm Dr. Mariam, a general cardiologist, and today I would like to talk about one of the common ECG patterns that we frequently encounter in the emergency department, a rhythm which diagnosis and management are both critical and life-saving. First, let's take a look at this ECG together. The patient is a 36-year-old woman who presented to the emergency department with a complaint of severe palpitation. I suggest you pause the video for a few minutes and try to make your own diagnosis based on this ECG. As we have mentioned previously, we usually interpret ECGs in a classic stepwise approach, and at this stage, we are focusing on rate and rhythm. For ECGs with an irregular rhythm, such as this one, the heart rate should be calculated by counting the number of QRS complexes in 6 seconds and multiplying by 10. Using this method, the heart rate in this ECG is approximately 200 beats per minute. The next step is to identify the rhythm. We know that we are dealing with a tachyarrhythmia, and at this point, we should ask ourselves two key questions. Do we have the regular rhythm or an irregular one? And for the second question, do we have a narrow QRS complex or the wide one? As you know, the definition of wide QRS complex is more than 120 milliseconds. The answer to these two questions lead us to the conclusion that this ECG represents an irregular wide complex tachycardia. So far, we have completed most of the diagnostic pathway. Next, we should consider the differential diagnosis of an irregular wide complex tachycardia, which include three main possibilities. The first differential diagnosis can be atrial fibrillation with aberrancy. This usually occurs in the presence of a bundle branch block, such as left bundle branch block or right bundle branch block. The best way to confirm this diagnosis is to have access to a baseline ECG showing a pre-existing bundle branch block. If a baseline ECG is not available, another helpful clue is the presence of QRS complexes with a uniform morphology, because when the impulse originates from a supraventricular source, the QRS complexes tend to look similar. In this ECG, however, the QRS complexes are not uniform, which makes this diagnosis less likely. The second differential diagnosis would be polymorphic VT, which means polymorphic ventricular tachycardia. Again, a baseline ECG can be helpful here, as it may show clues suggestive of ventricular arrhythmia, such as a prolonged QT interval or frequent PVCs. In the absence of a baseline ECG, polymorphic VT should be suspected when the QRS morphology is extremely variable and exaggerated. It is also important to remember that polymorphic VT is usually not a sustained rhythm. It either spontaneously converts to sinus rhythm or rapidly deteriorates into ventricular fibrillation. And considering all these points, this diagnosis also less likely. The third differential diagnosis is atrial fibrillation with Wolff-Parkinson-White syndrome. This condition is also known as pre-excited atrial fibrillation. In this scenario, as you know, when it comes to Wolff-Parkinson-White syndrome, there is an accessory pathway in addition to the AV node that conducts electrical impulses. Depending on the degree of conduction through this accessory pathway, QRS complexes with varying morphologies may be seen. Occasionally, a delta wave may also be visible on this ECG, which can further support this diagnosis. Considering all these points, the most likely diagnosis in this case is pre-excited atrial fibrillation. Now, let's discuss the management. The first and most important question in any arrhythmia is the patient stable or unstable? Signs of hemodynamic instability include hypotension, chest pain, pulmonary edema, and altered perfusion or mental status. If the patient is hemodynamically unstable, the treatment is immediate electrical cardioversion. If the patient is stable, pharmacologic therapy may be considered. Because an accessory pathway is involved, using only AV nodal blocking agents can be extremely dangerous and may precipitate ventricular fibrillation. According to current guidelines, only specific medications may be used in this setting. With class of recommendation 2A, the medications in pre-excited AF is prokinomid, ibutylid, felecainide, and propafenone. And if these medications are not available, electrical cardioversion is the only appropriate treatment. Some notes about cardioversion. In the past, a stepwise approach starting from low voltage shocks was recommended. However, recent guidelines suggest that in pre-excited AF, cardioversion should be performed with high voltage from the beginning. Typically, 200 joules would be good. If the defibrillator is able to detect QRS complexes, synchronized cardioversion should be used. And if the rhythm degenerates into ventricular fibrillation, as you know, unsynchronized cardioversion is required. The take-home message for this ECG is pre-excited atrial fibrillation is a true cardiac emergency. If you encounter this ECG in the ER, connect the patient to a defibrillator immediately to avoid delays if cardioversion becomes necessary. Avoid patient transfer until the patient is fully hemodynamically stable. Never use AV nodal blocking agents such as beta blockers or digoxin in this condition. If the patient is unstable, do not hesitate. Cardiovert immediately. And as usual, when it comes to heart, every second counts. Thank you so much for staying with me. I will see you in the next video. Bye.